just starting with us today. I'm Dr. Kevin Lombardi. I'm a medical doctor and epidemiologist with the Center for the National Center for Health and Public Housing. And I'm happy to have you today as we discuss screeners and their application.
Okay, thank you so much, Kevin. So my name is Frida Pineda, and I welcome you all for joining us today. Thank you so much for joining us today on today's session as well. And this is just some background information about NCHPH before we get started. The mission of NCHPH is to strengthen the capacity of public housing primary care grantees and other health center grantees by providing training and a range of technical assistance. NCHPH is a project supported by the Health Resources and Services Administration and is also a national training and technical assistance partner that is 100% financed by this grant. The information presented today are those of the author only. Okay. All right, and this is just some background information about the health centers that are close to public housing. According to 2021 UDS data, there were 1,373 FQHCs that served to 30 million patients. 458 FQHCs were in or immediately accessible to public housing that served to 5.7 million patients, and 108 public housing primary care grantees served to over 900,000 patients. And also, in case you are new to this learning collaborative, this is just some other information that we're going to review today. This is information about public housing demographics. This is also according to 2023 HUD statistics report. And in public housing, there were 1.5 million residents with 2 persons per household, 91% that were low income, 32% that were female-headed households with children, and also 38% that were disabled, and 36% were children, 19% were elderly. In terms of race and ethnicity, 52% were white, 43% were African-American, and 26% were Latinx. And now,
okay. Just to grab the ball, today we will be focusing specifically on screeners and really navigating some of the frustrations that folks have when using screeners and applying them into workflow appropriately. This is a key component of SDOH program design that often causes frustrations. Organizations are well aware of the sensitivity of collecting SDOH data, and fitting SDOH screeners into existing data management and workflow. These dynamics pretty consistently cause difficulties in planning and integration, and they can be debilitating and very seriously affect our ability to start programs, do programs, and affect patients' lives. So we're going to follow a narrative based on the literature, what the science says, and the case studies, what people are doing. Essentially, we'll start by kind of looking at the use of SDOH screeners, what they're used for and where they can be appropriate. Review the key SDOH screeners and their specific applications. And 3, the ways to modify SDOH screeners to meet community needs. Next slide, please. And just the conceptual overview of SDOH. These diagrams, when we see them, they're meant to impart a way of thought or way of systemically seeing health as the whole human environment and recognizing how that environment is critical to health. I'll be referring to these diagrams throughout the lecture today. Next, please. So to start with the discussion question, SDOH screeners are used by organizations in a variety of different settings and patient care scenarios. And before we look at this, I want you to consider the following questions. Please take 2 minutes to answer the following. In what situations does your organization use SDOH screeners? And for which scenarios is your organization considering use of SDOH screeners? So same format as in previous sessions. Please type or write your responses. And if you could please put those into the chat or raise your hand in 2 minutes. And we would love to hear your perspective and discuss the content more carefully. Thank you.
And then during COVID, I was doing vaccine stuff. It's not like we had it up all the time. They're like halfway like, so it grew. It got separately.
Oh, I can't wait. So it's to go to the rescue.
Sorry, we will start with hands if we have hands, and then Fide, if we could address the comments and if you could facilitate that, please.
Yes, of course. Again, thank you all for providing your responses. So I'm going to begin with Alejandra Mata. I see that you provided your response in the chat. If you could please try to elaborate a little bit more.
Hi, yeah.
Hi.
So for our SDOH screening, we utilize the Prepare assessment tool. A lot of our support staff or enabling service staff screen the patient for the entire Prepare assessment tool during their one-to-one visits, which is outside of the medical visit. So it's not when the patient sees the provider. However, we have 17 health centers, and about 5 of our health centers are screening for food insecurity during the well-child exam visit.
And if I could ask you a follow-up question on that, you mentioned screening about the food insecurity. Is that an addition that you're adding to the Prepare screen?
So it's actually part of the Prepare screening. So it's within our Prepare assessment.
And are you asking any additional questions that are related to program access in your community, or is this allowing you to connect people to specific resources?
Yes, so depending on which areas the patient screened positive on the Prepare assessment tool, the support staff will search for community resources on an online platform that we utilize. We use OneDegree. It's similar to like 211 and other online platforms for community resources. So the support staff will search for community-based resources based on the patient's SDOH need, and they will either text them, email them, or print out the resource for them to utilize it.
Thank you. Fide, could you pick another response, please?
Yes, for sure. So we have a response from Samantha Wall saying most of our health centers screen at intake. A few health centers are looking to adding screening in the outreach enrollment department. Samantha, would you like to provide more input on your response?
Yeah, so very similar to the previous commenter there, but most of our health centers that are screen during the intake and check-in process as well. But like I said, the enabling services department, specifically those assisters that are helping with insurance enrollment, are also looking to begin using the screeners in their department, as they do come across a lot of times somebody who's reaching out for help to get enrolled in insurance also has other needs as well. So that's a bit about what our health centers are working on.
Interesting. Samantha, if I could ask a follow-up, are you aware of how they got to the point where they were asking themselves that question? Was there something they were observing in their patient population specifically?
Yeah, so I work for a PCA, and many of our enabling services workers would be asking for resources. So they'd say, hey, these patients or these consumers are coming in, but they're also asking for help with food, they're asking for help with housing, and you know, we just need some extra support on how to manage that. And so it was kind of a natural fit for them to begin screening. Most of our health centers use a prepare screener as well. And so that's kind of where it stemmed from, was they saw a lot of consumers coming in with needs and they weren't sure what to do.
Excellent. That's encouraging to hear. And you may have mentioned this, but is this like somehow connecting to existing social services, or are those individuals doing that networking themselves with a separate person?
So the individuals that are screening would also be connecting them to the resources. It's still a work in progress in those departments, so it's not quite happening yet, but that's the goal, is that the person that they would be,
the Lowe's receipts,
the person that they would be talking with would be the one to help connect them to services.
Excellent. Well, thank you about those details. And Fide, we're going to go ahead and switch straight to the slides now, because this is actually a fabulous transition for us.
Mm-hmm. All right, give me one moment. I just had a minor technical difficulty here. Okay, perfect. Can you see the slides?
Yes. So let's go ahead to the next one, please. So I wanted to start by taking a SDOH screener and talking about adaptation. And this is a screener that's utilized in the pharmacy setting. And specifically, the screener covers a range of questions designed to meet that particular context. And I wanted to consider this. Looking at the screener questions to the right, to the side of the diagram, what questions are missing from this screener that might be helpful in your community? So if you please take a moment and consider that, and consider what would you add to this for your specific clinical context, and why. We will take 1 minute. Okay, and if you could please take a moment to put your response in the chat, or to raise your hand. And if you could facilitate that, please, Fide.
Okay. All right. So we have our response from Christian Vargas, who mentioned transportation services, food insecurity, healthcare, and healthcare accessibility.
And is there something you'd like to add about that, about those specific things you mentioned?
Yeah, of course, Kevin. So when I think about transportation services, food insecurity, and healthcare accessibility, those three factors are, some of the most important considerations to account for when we, screen for social needs for our patients and overall community members. And so I think that, just glancing at these screener questions, there's a lot of great questions included that are really essential. But of course, it made me think about, for one, do our patients have healthcare accessibility or proper accessibility and timely accessibility that, that provides them with high quality care? Not only that, but, when it comes to healthcare accessibility, do our patients have transportation services that are reliable, meaning that they are able to arrive to their appointments on time, meaning that, if there's a conflict of interest or anything along those lines, the transportation services are still going to be available. And then, of course, with food insecurity, number 5 is asking, do you always have enough food for your family? And of course, that considers food insecurity, but, I also think that asking some additional questions around number 5 would be really helpful to get a greater sense of, food insecurity challenges that our patients may be experiencing and that, we don't know about. So it's really important to consider not only the overall questions, but the underlying factors that might, might make an impact for these patients overall.
And I couldn't agree more. And I think, thank you for sharing that. I couldn't agree more. And in speaking to health centers in particularly rural areas, the transportation can be the primary concern or the primary barrier. So this speaks to the adaptation of the tool and making sure the tool fits what your community needs are and what your program outreach focuses. And transportation needs in certain communities, I can feel that quite a few more questions would need to be asked to really understand what that patient is doing and how they use their transportation and how they have it. So yes, I couldn't agree more. Thank you. I noticed Whitney Wright mentioned something about mental health and putting that in the screener. Whitney, would you be willing to share your thoughts on that with us?
Sure. Hello. I added that to what I would hope will go in the screener that we're developing right now to start on later this year, because Regenesis Healthcare actually has its own behavioral health department. We have a little less than 30 school-based counselors that primarily work with youth. And we do require that adults seeking behavioral health services from us see us for their primary care needs as well. Those appointments can be accomplished either on site or via telehealth. It just seems to be something, I guess, because there's still some stigma in some communities surrounding mental health issues that a lot of people won't say anything about unless they're asked directly, but still discreetly. And so that was a concern too, that I had in talking that over with other colleagues about how to effectively text message someone, knowing that someone else may look at their phone and they may not want you to send them a question like that, if they don't have a lot of privacy at home. So it's like, how do we word that question without offending someone or making them feel as though they can't answer honestly?
Yeah, I appreciate the thoughtfulness in describing that and the thoughtfulness that clearly went into the process. And what I find really interesting about that is it speaks to the importance of working within your organization's strengths. If you have behavioral health in-house and the screener and should be a reflection of the services that are available and the services that you feel strongly about. And that's an appropriate intervention on the screener there. But also the process of discussing it and coming to the conclusion that, hey, this is something we should do, is a conversation that needs to be, needs to involve multiple parties. So I appreciate you for detailing that for us. Thank you.
Welcome.
And Fide, if we have any hands, we'll get that. If not, we will go to the next slide, please.
We don't have any hands at the moment.
Okay, next slide, please. So just to reiterate, screeners are made for specific purposes. They're tools with things in mind. And there are a lot of different contexts that we want to measure SDOH and we want to help our patients. And adapting those tools can be difficult, but necessary to reflect the needs in our communities and the unique needs or unique skills and services that our organization has. These should also reflect partnerships. If you have a strong partnership with a legal aid organization or a strong partnership with a housing organization, maybe a focus more on housing would be appropriate. And so just looking at this, like this screener focuses mostly on neighborhood and built environment, but as you can see, it's missing a lot of key things that may be important in different contexts. Another consideration, specifically, some communities are having issues with lead. Some may want to ask questions about lead poisoning age of houses. More information on family networks may be important or specific to the immigrant groups that live in your area or the migrant groups. More information on area of the town or county where someone lives may tell you a lot about the services that you can network them and so forth. So adaptation of these tools is incredibly important, and the process to doing that is important as well. And if we go to the next slide, please. Okay, case study. An Ohio-based primary care clinic is considering screening for SDOH in their office. Currently, these data are collected by nurses or physicians during the patient visit. An internal review of SDOH policies was performed by the office's health system, and the following conclusions were made. 1, patient surveys indicate SDOH needs were not being met. 2, social services staff were experiencing high levels of burnout. 3, nurses and doctors often do not coordinate who collects these data, so the collection is rushed or ad hoc. 4, medical records could be submitted without collecting these data, so someone could submit their form without this being completed. And 5, failure to collect SDOH data was leading to lower Medicaid billing and reduced system revenue. So all of these point to a general issue with the SDOH screener that's affecting the organization in a variety of ways. Next slide, please. So considering this, what are some actions this organization could make to improve their use of screeners? We will take 1 minute and start now. And another 30 seconds, if you could please put your responses into the chat or raise your hand. Fide, can we go back to the case study slide and we'll spend another moment on that? Then another 15 seconds. Okay, do we have any comments or hands? One moment. Susan Adams, I see your response. Would you like to share more with us?
Can you hear me?
I can.
Okay, so we've been trying to work on this off and on for the past year when we saw that it was all coming down. So we've been trying to, as I call it, have aces in their places, people that can handle these things, and then have a direct like algorithm of who goes to which area. So some of our things that we can do referrals through, we try to do, we have a couple people appointed that these go to, we examine them and see where they can go. Sometimes if it's for like food or things like that, we have local resources, but we also have like find help for like people who need caregiver assistance or respite care and things like that. So we're still in the development process, but we're trying to learn who those aces are in their places. And so we do it by a referral so that it is tracked in our computer. A copy is given to us girls, and then we kind of decipher and disseminate from there.
Well, I appreciate the pragmatic control of the focus on this, and I think you're speaking to a complexity that a lot of us experience, and it's sometimes the resource environment is incredibly complex, and the screener is if the screener is the network to those resources, then sometimes it can be very difficult to find which questions to add, which will network to resources, and so forth. We'll be going over some details of that process in slides in sort of a few moments, but process and structure are the ways that I typically address that issue, and really being able to map what the resources are, what the structure of the resources are, and how to integrate that into the screener. Thank you for sharing.
No problem. We also call to follow up with them too if there's something, because some of the screening questions are a little vague. So we do try to figure out if it's something that we're like not clear on, we will call the patient. And I know staffing is an issue for everybody because everybody's busy, but we prioritize and make a call if there's something that we absolutely know is, you know, detrimental right this moment, in addition to the fact that we might need more information.
I see. And how has that approach been? Have you noticed success or issues? What's been your observation?
Patients are actually super happy to hear from us. I work in chronic care management normally here, and so I do have the rapport with a decent amount of the community that goes with that end of it. But just even our other patients who aren't enrolled, when I call them and I'm like, hey, we saw this was marked on your screener, and we're trying to figure out, you know, what's going to be the best fit to help get you assistance. Like, are you having trouble getting food every day, every week, once a month? Are you running out before the end of the month? Trying to figure out how we can address and meet those needs for their specific entity. And if they need to, you know, do they need to apply for food stamps? Like these types of things, to try to get a little bit more information so that the screener is actually purposeful and not a waste of their time or ours. And when they see the response coming, they are more likely to answer the questions in the future and answer them honestly, because they know there's going to be someone checking on them.
Yeah. So you mentioned a couple of very important things here. And like, it's really the effectiveness of the screener is really important for patient trust. When folks are answering these questions, they want to be able to know that something's going to be happening, that this isn't just data collection. And also it affects the staff as well. And if you don't mind my asking, are you a community health worker in social services in some capacity?
No, I'm an LPN, and I kind of wear multiple hats here. I work mostly, like I said, with care management. I do diabetic CGMs and things like that. So I kind of have my hand a little bit in everything. But we don't have community health workers. So we're small. We have 900 people in our town, like 3,500 in our county. So it's a little different than probably a lot of places, because when you're part of a community that's so small, you are seriously like truly part of the community, not like in a big city where it's just a small portion of it. So we're able to meet needs, and people talk and share. Sometimes I get calls from a neighbor of a neighbor that's like, hey, this neighbor's got this going on. And we, if they're our patient and we know them, call them and be like, hey, did you need some help? And so it's a little different here, but it's great.
Well, I appreciate those details. And I think it speaks to the potential of when you know your community and you know what those social connections are, and you seem like someone who does. And in many ways, you are functioning. One of your hats is community health worker and social worker. I'm certain that you're not the only one on the call that has those on their rack. And being able to understand that is a key foundational principle to being able to appropriately use the screener. So thank you for that.
Thank you.
And
We try.
Excuse me?
I was just saying, thank you. We do try really hard.
You're welcome. Fide, if we could go to the next slide, please. So what we have is a system that is struggling with screener use, and specifically where to put their screener and how to get people to actually use it. These are problems that are endemic with screeners in general. We had similar issues with our smoking screening when I was in residency, in that it often wasn't done or not done in the appropriate scenario, and we required training to make sure we remembered where it was and remembered where we were to do it. So some recommendations based on this case. One, and some best practices. One, it's ensuring that a screener can be completed and that screener, if it is integrated into an EHR, that it needs to be completed in order for the EHR to be finished. Also, sometimes people put timers on forms to ensure that they're done appropriately, and to make sure that it's in workflow in a place where employees can do it comfortably and within their time restraints. Regular data audits can be performed by third-party vendors or your internal IT department to check the quality of the data. And that may be available in your system and you may not know. And the complexity of the EHR integration. If you are integrating your screener into your EHR, or you're interested in doing that, having a conversation with the right people can help guide you of how to do that. EHRs are very different, and your system administrator will have a good understanding of what the system is and what's in your power to change and how you can change it. Next slide, please. So now let's discuss the application of screeners. Screeners are placed at key locations in workflow to ensure that SDOH data is collected responsibly and informs the key steps in the patient care continuum. Where you perform your screening is going to depend on your organization's unique patient care and workflow needs. And when planning to implement a new screener, my recommendation is to look at your organization closely and consider the following. If we look at sort of the basic framework of intake to consultation to follow-up engagement, and you either, one, have a screener already, or two, are thinking of putting a screener, consider the following. So if it's a new screener, taking a good look at your organization's workflow and seeing realistically where we can do this. Realistically, who are the right people? When are they seeing the right patients? And how can we give them the time and the tools to do it? Two, identifying key patient care interactions. Where people are seeing the patient and how they are seeing them can inform if it's an appropriate use of a screener or not. Consider data collection. Looking at how the data is saved at your organization, what it's used for, are very important, but also making sure that you use data hygiene and data management and stewardship policies that allow data sharing within your organization and between your organization is very important. And if those questions are things that you can't answer, speaking to your IT department or your data steward at your organization is an important first step. And consider the screening design. A little different from when you're working with an existing screener. One, examining the organization structure is still important, but take a detailed look at where the SDOH data is collected and see if it's appropriate and it's effective. And if you're finding that there's issues with the collection of the data, or that data is not translating into real change for the patient, then there's a problem there. And asking those questions are a necessary component of solving that. And also the importance of data ethics. SDOH data is very, very intimate and is very personal data. It's among the most intimate personal data we can give. Luckily, healthcare gives us a framework for working with this and working with this kind of data, and using the same ethics and integrity we take to medical data and taking that to SDOH data as well is a necessary thing to consider. Next slide, please. So just some a quick diagram on where SDOH screener would be used in this application, and specifically an intake and follow-up and engagement. Intake and follow-up and engagement are two main areas where people use the screeners for different purposes. On intake, the screener informs us of what the patient needs and how we can help them. That data is also important for tracking, evaluating quality in our system, and evaluating equity in your system. But follow-up engagements, especially for those who have community health workers who are working long-term with the patient, integrating screeners periodically within the follow-up process allows you to see what the progress has been, where support may be needed, and how effective your programs are. Keeping a good eye on this data and this information is a good way to assess the effectiveness and efficiency of how you're giving this information, and the effectiveness of your patient supports. Next, please. This is just where the screeners would go for a similar situation. Next, please. So let's take a moment and talk about the adaptation of screeners. In speaking with organizations around the country that are doing this, there's a lot of trepidation with working and changing screeners. And the main concerns are as follows. The integrity of the screener. Folks are often concerned that if they add things to or change the existing screener, that they're somehow altering its integrity or making that process less scientific. And the second is the use of the screener data itself. And I have here the link to a fabulous publication, LaForge et al., which is worth a morning read. This publication looked at 6 organizations that did exactly that and adapted a screener to their local community needs, rural, urban, Spanish-speaking, or whatever those are. And specifically identified key areas where it's okay to change the screener and it's okay to add these questions, and opportunities to add those questions to link your patients more effectively to services. And the recommendations are that is okay to do. And the recommendations are that it's appropriate and effective as well. So when you're using screeners or considering screeners, it should be part of a larger conversation about general quality improvement in SDOH program design and how to effectively use them. Next slide, please. Now let's talk about sort of the process of how to do that, how to change the screeners, and how that can be managed. Take a moment, and if you use prepare, please put yes in the chat. I'll take a look at that in a second. But the prepare tool is the most frequently used at the health centers we speak to, and it's the one that's most frequently altered too. The prepare tool is great because it's very well designed to be a foundation screen. And specifically, it looks at all of the social determinants of health in a broad way that is very general and can apply roughly to most of the United States. Something I hear very frequently is about adapting it to local community needs. And some of the needs that have been discussed just in this presentation, things like transportation, food security, housing, other social services, the details of what you have available and what you're trying to network patients to can inform those additions. A good example is adding more questions about transportation, more questions about housing. For example, if your community has old housing stock, it may be appropriate to ask if there's lead paint there, especially in a pediatric appointment or in a pediatric office. In parts of the country, there are heaters that are still used that are fire hazards. And if you know you're in one of those communities and that's frequent and people experience that, adding a question specifically about that may be appropriate too. The difficulty is that we are all coming from very different organizations with very different histories and organizational structures. And the important thing to keep in mind is adapting the screener to those needs and to your specific patient needs. And that's often part of a bigger conversation about SDOH and about screeners and diversity at your organization. Next, please. So as we're talking about screeners and screener use, data stewardship and data integrity and all of the associated best practices are things to keep in mind. An important piece of component that often causes a barrier is how organizations look at ethnicity and race on their screeners. The OMB 2+5 standards are standards of looking at ethnicity and race that are used fairly uniformly across the United States and in research. What's very common is that organization will add categories or will change categories to meet the specific diversity in their community. And that's an important piece, an important way of understanding and knowing your community. But when you are doing that and when you are adapting a question, a questionnaire, or a screener to meet that diversity in your community, keep these in mind. Because if you are able to, any extra categories that you add or use, you may need to keep in mind how to put these into these categories. Because if you are in a data sharing agreement and you have different groups, types of people mentioned in your screener, and the other organization does not, that could be a barrier to data sharing and putting databases together that could stop collaborations or could stop the creation of new collaborations. It's something that I've heard a number of times. So staying consistent with that is something to keep in mind when making your screener or adjusting screeners at your organization. Slide, please.
Hi, Kevin. I don't know if everybody's having the same issue, but I'm having some trouble hearing. Maybe it's just me.
I cannot hear anything either.
Okay, yeah. Maybe there's something wrong with the connection from your end, Kevin. Yeah. Yeah. My apologies for this inconvenience. Just give me one moment, okay? I'm gonna try and do some troubleshooting here. Hi, everyone. Our sincere apologies on this. Unfortunately, Kevin's internet just crashed. So he's very sorry about that. So what I'm gonna do right now, I'm just gonna go over the final slides, and then we will recap on where we left off in our next session. Just a reminder for everybody that our next session is next week, on the same day, on Wednesday, on June 21st at 1 p.m. Eastern Daytime. And you can also use the same registration link that you used today. And also just a reminder to everybody to please complete our post-evaluation survey, which will be provided to you right after today's session. And this is our contact information. If you have any questions or anything that you would like to follow up with Dr. Kevin Lombardi based on today's session, you can just go send him an email to kevin.lombardi@mgt.com, or you can also send me an email to fide@mgt.com, and we will get back at you as soon as possible. So if you have any questions, please just let us know via email. And again, we apologize for the inconvenience, but we will have to cut this off early today. All right, thank you, everybody. Have a great rest of your week.
Thank you.
You're welcome.
Thank you.